Morning, Ava. Should I go ahead and start?
Yep, please go ahead.
Okay, good morning, everybody. I am Victor Davila, the Associate Director of the Global Health Center in the Institute of Public Health at Washington University. This week, we celebrate the 6th annual Global Health Week at Washington University, a university-wide initiative organized by the Global Health Center that involves participation of all 7 schools at the university. The purpose of Global Health Week is to foster engagement in global and regional health-related issues and discussions. There are a few activities remaining this week listed on this slide, including the elimination of cholera in Africa by David Sack from Hopkins, building new partnerships, finding common ground for successful actions by Daniel Wildcat, and Let's Talk Diverse Global Health Careers organized by the Global Health Student Advisory Committee. Next slide, please. Today, it is my pleasure to introduce the speaker for the Internal Medicine Grand Round, sponsored by the Department of Medicine and the Global Health Center. Dr. George A. Mensah is the Director, Center for Translation, Research and Implementation Science at the National Heart and Blood Institute. He also serves as Senior Advisor, Office of the Director, also at NHLBI. In this position, he leads integrative trans-institute efforts to advance the translation of scientific discoveries in heart, lung, and blood disease research to clinical and public health practice nationally and globally. Dr. Mensah graduated from Washington University School of Medicine in 1985, and he is a proud alumnus. In medical school, he trained in internal medicine and cardiovascular disease. After that, he went into direct patient care, teaching and research, serving at Vanderbilt University, Medical College of Georgia, where he was a tenured professor and director of the medical specialties practice and department head of cardiovascular care at the VA Medical Center in Augusta, Georgia. After that, he worked at the Center for Disease Control and Prevention in Atlanta, where he held several leadership positions, including the first chief of the cardiovascular health branch, as interim center director, and as chief medical officer at the National Center for Chronic Disease Prevention and Health Promotion. He also served as vice president for nutrition science within the Global Research and Development Unit of Pepsi Company, a multinational food and beverage company. Dr. Mensah's professional interests are in the application of implementation and system science to address research translation gaps in the prevention and treatment of heart, lung, and blood diseases, and in the elimination of health disparities. He has authored more than 400 manuscripts, abstract, book chapters. He recently served as chairman of the Cardiovascular Expert Group of the Global Burden of Disease, a multidisciplinary, multinational group based at the Institute for Health Metrics and Evaluation at the University of Washington. It is indeed a great pleasure to have at today's Internal Medicine Grand Rounds, Dr. George Mensah. The title of his talk is Grand Challenges in Global Health from 2020 to 2030 and beyond. Dr. Mensah, welcome back to Washington University in St. Louis. And we're looking forward to your presentation today.
Thank you very much. Let me make sure, Dr. Cadwata, are you able to see my?
Everything looks great. Thank you.
Excellent. Thank you. I am indeed a proud alumnus, and I want to thank Dr. Davila for the wonderful introduction. The one thing he didn't mention, though, was that I also met my wife at Washington University some 36 years ago, and we've been married now for about 26, 27 years. So I'm very, very proud of the relationship that I have with Washington University. I'm a doctor today because of WashU. So accepting the invitation to come speak was very, very easy. So thank you very, very much for inviting me. I should mention that no question at all, a lot of people work very hard to make all your activities this week happen on time with perfection. And I'm very grateful for those who helped get me ready for this presentation. In addition to Dr. Davilá, I want to thank Dr. Ava Kaidiwada, Dr. Jacaranda van Reenen, and certainly Holly Steinberger and Andrea Sunderman. They all were extremely helpful. I'm very, very grateful for that. I should tell you that I have no conflicts to disclose. And even though, as you heard from Dr. Davilá, I am from the National Institutes of Health, nothing I say here today should be construed as necessarily representing an official position of the NIH or the United States government. Let me make sure that I can. Okay, I may have to default. Something is out of sync, and so I will have to make do. On this slide, I'm showing you the lecture objectives. And my hope is that by the end of the lecture, you'll be able to identify the 5 major insights from the most recent global burden of disease study. In addition, you'll be able to describe the major trends over the last 30 years when it comes to the leading cause of death in the world, cardiovascular diseases, and why there is a real reason for all of us to be concerned. You should also be able to articulate the implications of these trends for the burden of disease now and in the next decade, especially put within the context of population growth, population aging, and social determinants of health. And then finally, to be able to highlight best practices for effecting change at the local and global level. Let me try again to see if this works. Okay, I have a little disadvantage here. Something is out of sync. I'll try to accomplish these objectives, segmenting my presentation into 4 parts. I'll first give you the 5 insights, and then address the major trends, then spend just a little bit of time on the implications for the cardiovascular disease burden now and 2030 in the next decade, and then address the best practices and the need for implementation research. So first, the 5 insights, but I think it's very appropriate since most of the data I'm going to be sharing with you have to do with the global burden of disease, that I share just a little bit of that effort. This is a major effort undertaken by the Institute for Health Metrics and Evaluation at the University of Washington. That effort covers more than 204 countries and territories, as well as for some 20 or so large countries such as India, China, Brazil, Nigeria. It also offers sub-national data assessments. We look at over 369 diseases and injuries using the International Classification of Diseases. It's a huge amount of data sources, nearly 282,000. And in the end, when the effort is completed, we have more than 3.5 billion estimates. You can imagine all the diseases and risk factors, looking at multiple summary measures of health for all the different countries and over several years looking at trend. It is very, very standardized. It's very comprehensive. And we look at both fatal as well as non-fatal outcomes. In both the presentation and the handout that I've provided you, I've given you the hyperlink so that you can actually look at all the estimates because we follow the GATHER guidelines, which is the we're very much adherent to the guidelines on accurate and transparent health estimates reporting. You can look at both the estimates as well as the GATHER resource itself. And most of the data I'll be sharing with you have been published in several papers in the Lancet. I'm actually very pleased to say that this is a multinational effort. As you see, most of our collaborators are from North America, but also Australia, India, and certainly Washington University contributes several outstanding faculty, and I'm very, very pleased to mention Dr. Al Ali, Dr. Randall Martin, Dr. Hammer, and Dr. Dunkelar, some of the few. And these are only the ones who are on our insights paper published in October in the Lancet. There may be several other faculty who I haven't listed here. So let's briefly go over the 5 major insights. And the first one, very important, and put very simply, social determinants are important. If you look at social and economic development measured with the social demographic index, you find out that it's very highly correlated with health outcomes. So what that tells us is it's important to address social determinants of health in addition to addressing the biomedical and technological advances. In the image that I have included, you would see that if you look at social demographic index broken down by quintiles, here low SDI representing most of the low income countries, and the high SDI representing the high income countries, the vast majority of the component of changes in healthy life expectancy are attributable to changes in social determinants, with the rare exception. And in fact, the portion of the improvement that is not explained by social determinants, these are technological advances, new drugs, new devices, new surgical interventions, it's really a small portion of the contribution to the overall improvements in life expectancy. So social determinants are important. The second insight in our paper is that over the last 30 years, we've actually had some progress that we have to be very proud of. And the progress has been mostly in communicable diseases, in maternal, neonatal, and nutritional diseases worldwide. And in fact, most of that progress, the rate of that progress has been fastest in the last decade. At the same time, however, if you look at non-communicable diseases, that level of progress has been minimal. And if anything at all, in some middle-income countries, the burden of chronic diseases is rising. So globally, the message is, yes, we've had progress in communicable, maternal, neonatal, and nutritional diseases. We need to continue that progress, but we also need to pay attention to non-communicable diseases because that is what is rising. Here, I'm showing you 4 bars for each of these 3 major categories of diseases. To the left here is the communicable, maternal, neonatal, and nutritional diseases. In the middle is the non-communicable diseases, and to the right is the profile for injuries. And what you see is here we're looking at the annualized rate of change for DALYs, which is the disability adjusted life years. And you see that for the period of 1990 to 2010, there was some progress, and that progress was even more in the period of 2010 to 2020. This is looking at rates. But when you look at the actual absolute value of DALY, same thing, substantial improvement the first 20 years, 1990 to 2010, and even more in the subsequent period. When you look at injury, similar story, improvements in the rates, some improvement when you look at absolute counts. But for non-communicable diseases, the annualized rate of change for both periods, 1990 to 2010 or 2010 to 2019, less than 0.5% improvement. But what should be more concerning to all of us is this increase in the absolute DALY counts, and I'll get to that later. The third important insight is that many low and middle income countries, especially the ones that have a rapid transition from communicable to chronic diseases, what we've traditionally called the epidemiologic transition, they seem to have a very, very low health service coverage for non-communicable diseases, even though they do very well with communicable diseases. So the message is that for these countries, we need additional focus on the prevention, the treatment, and the control of these chronic non-communicable diseases. The data I'll show you here is fairly simple. Here we're looking at the average universal health care coverage. You can interpret this as evidence-based effective coverage. The red dots and the regression line reflect the magnitude of the effective coverage depending on the social demographic index. So for high income countries at the very end here, there really isn't a big difference between coverage for communicable diseases in the red and the chronic non-communicable diseases in blue. In the very low income countries, again, we have sparse data, but not a big difference. But what I want to point out is in the countries in this middle income group here, where they've made tremendous progress, effective health service coverage for communicable diseases. You have malaria, you have TB, you have HIV, coverage can be as much as 75%. But if you have hypertensive heart disease or diabetes or cancer or stroke, the coverage is around 20-25%. So there is a big gap that we need to address. Very important insight. Now, the fourth insight is important, particularly for women's health. Now, back in 2019, things seem to be moving so fast that at least the most recent data in 2019, 34 countries had negative natural rates of population increase, meaning the crude death rate for the country was greater than the crude birth rate. More people were dying than were being born, so the populations were shrinking. The problem is that the modeling data suggests that there will be a very rapid increase in the number of countries that have this phenomenon. And one way of addressing that is rapidly trying to increase fertility. This is going to have an important impact on women's health, on the health of girls, the education of girls, particularly in low and middle income countries, and it will have an impact on overall health. So we need to be mindful of the policies that are adopted to address this phenomenon so that we can take appropriate strategies to ensure effective women's health overall, but also reproductive health. The final insight has tremendous relevance for the next segment that I will address, and that has to do with the fact that all the evidence suggests that globally, we are failing to address the increases in the crucial global risk factors that account for the major burden of disease. Now, in this figure that I'm sharing with you here, we have ranked these risk factors, the risk factors by the magnitude of their contribution to disease burden. So hypertension and smoking and dietary factors contribute a lot relative to high temperatures, intimate partner violence, and childhood sexual abuse. All of these are important, but looking at attributable risk, obviously hypertension, smoking rise to the very top. So that's one message you should get from this chart. The second is each risk factor has been color-coded and has been given a number. So the dark blues, as you see here for household air pollution, reflects the largest improvements or the largest declines in the magnitude, whereas the red, not so good. So high body mass index or high fasting plasma glucose or high systolic blood pressure are the parts where they're either increasing or not improving enough. And the message here is the public health action and public policy needs to stop and reverse the rising trends in these major risk factors. So really paying attention to high systolic blood pressure, high fasting plasma glucose, body mass index, air pollution, as well as adverse use of alcohol and drugs really can play a very, very important role. So risk factors are important, and we should be really paying attention. I don't want to point fingers at any countries, so we're using our own country as an example. This is looking at the prevalence of controlled blood pressure using the enhanced data, and we are all very, very proud of the progress that was being made. Here we're looking at the enhanced cycles from 1999 through the 2000 period, 2000 through 2004, all the way through 2008. We were just making progress, and we're all very proud of that. From the period of 2009, 2010 to 2013, not much of a change, if anything at all, a slowing of the slope. I think we can all appreciate it. But over the last 3 cycles, there's been a clear decrease in the proportion of people with hypertension that is controlled. This left figure reflects all adults with hypertension. But even when we look in those who have hypertension, they and their doctors recognize they have hypertension. They are taking medications to control hypertension. That control rate is getting worse. So really important that our public health actions, our clinical practice actions all need to help address this phenomenon. And it's not just blood pressure. As I showed you, it has to do with obesity, it has to do with diabetes, and we all need to find ways to do better. The DECIPHER Initiative is just a multi-million-dollar effort we're beginning to fund this year. We have 7 sites that are funded, and as you see, we pay a great interest to high-burden communities from Appalachia and Mississippi Delta, the stroke belt, also rural and inner-city populations, and certainly certain underserved racial and ethnic populations. Of the 7 programs, it will come as no surprise to you that 3 out of the 7 of the newly funded projects are focusing on disparities in treatment and control of hypertension. What's missing here is we also need to find strategies to prevent hypertension in the first place. I want to now turn my attention to share with you some of the major trends we've seen over the last 30 years. Taking the specific example of cardiovascular disease burden. Now, I use the term grand challenges very loosely. This is not a reflection of the grand challenges in global health effort that was funded by the Bill and Melinda Gates Foundation and the NIH. This paper, written by 2 NIH directors and our partners, addressed that. I think it's important. When you have a chance, take a look and read that paper in Science. But for the presentation today, I'm looking at grand challenges as important problems based on the data that I've shared with you that suggests that we need to come up very quickly with programs to develop and test how we can use best practices to solve these challenges, because they would lead to tremendous improvement in lives saved. The first major trend is that when you look at the prevalence of cardiovascular disease over the 30-year period from 1990 to 2019, the prevalence nearly doubled. So if anybody tells you that we're winning the war on cardiovascular diseases, just remind him the prevalence has doubled. Now, we know that an important part of that is population growth, population aging. Maybe not as many people are dying from heart attack. That's a good thing. But more people are living with damaged hearts. Maybe we need to spend a lot more time in preventing the risk factors that lead to heart attacks in the first place. It's good to find new treatments. It's good and wonderful to find new surgical interventions, but we also need to do our best, because healthy aging, I'll get to that in a minute, is really important. So the burden of disease has doubled. If you look at deaths have also steadily increased from around 12 million in 1990 to about 18, 19 million in the last year, 2019. Now, premature mortality, dying before the expected life expectancy or dying before age 75, as well as disability adjusted life years, which combines years of life lost because of premature death and years lived with disability, both have increased significantly. If you look at years lived with disability alone, that's more than doubled, about 17 million to about 34.5 million. And finally, if you look at the total DALYs, again, a combination of premature mortality and years lived with disability, you look at it for stroke or ischemic heart disease, both have gone up. Where are these data the worst? And sometimes knowing this information can help us design either natural experiments or observe from natural experiments, or examine what can be done differently in order to change things where the burden is worst, or also learn from practices that have led to low rate. So if you look at these Eastern European countries and also small island nations, rates for age standardized cardiovascular mortality rates exceed 600 per 100,000. That's high. And you know that's high because if you compare those to where these rates are lowest, say Japan, in Peru, France, Singapore, Republic of Korea, or Israel, the rates are about 6-fold lower, around less than 100 per 100,000. So big differences. What's contributing to these differences, and what can we do to make changes? If you look at the period from 1990 to 2019, there have also been dramatic declines in the age standardized rates of death. Again, a good example, fewer people today die from myocardial infarctions. The age standardized rates for these summary measures of health, whether you look at mortality, disability adjusted life years, or years lived, years of life lost, what this suggests to us is that the global increases in the total cardiovascular disease, an important contributor to that is population growth and population aging. And so this should feature into the designs of the interventions that we address. A picture sometimes is worth 1,000 words. Here, you can create these images yourself. I've shown you the link to the visual visualization data hub at the IHME for the global burden of disease. And here you see the Russian Federation, most of Eastern Europe, Middle East, and North Africa. These red hues suggest very high percentages of cardiovascular disease contributing to total deaths. And the low rates, again, seen in parts of Central Africa for cardiovascular diseases. If you look at age standardized mortality for total cardiovascular disease, again, similar story. The worst data tend to be seen in the Eastern European countries. Another image here looking at ischemic heart disease alone. Most of the progress we've seen, Australia, Canada, parts of North America, some parts of Latin America, but real concern, again, Eastern Europe, as you see in the shades of red and bright yellow. The picture's a little different when you look at some of the major risk factors. And here I'm showing you the data for systolic blood pressure as a measure of hypertension. And this is just looking at 2019. The dark reds reflect exposure levels of around 50%, loosely translated to prevalence, and the dark blues, the low rates, 15-20%. So North America, not bad. Parts of South America, not bad. But the real concern is the low and middle income countries in Sub-Saharan Africa, particularly Nigeria, showing very, very high here, and certainly the Russian Federation, Eastern Europe again. Now, there are conditions that are endemic to certain areas, and rheumatic heart disease is one example. And as you can see, for most parts of the world, we show the deep blues that are on the low end here. Here we're looking at age standardized prevalence, so it enables us to be able to compare. But you see the very heart rates, again, parts of Eastern Europe, but certainly Sub-Saharan Africa, very high, Central Africa in particular, Brazil, parts of Latin America, very important. These visualizations are important, at least they give you a picture where the burden is. And if you're thinking of new grants to prepare, it helps when you highlight how huge the public health burden is. I want to look closer to home. Our data for 2019 is not ready, so I'm showing you what we published in JAMA for the data for 2016. And here we're looking at the major cardiovascular risk factors, all the way from air pollution, tobacco use, dietary risk factors, high systolic blood pressure, and high systolic high body mass index. And along the y-axis, each of these bars reflects one of the 50 states and the District of Columbia. And as you see, this is dietary risk, this is systolic blood pressure for hypertension, and this is body mass index for obesity. And most of the burden is driven by these major risk factors. Again, diet, obesity, systolic blood pressure, hypertension. But there are areas where we do better than others. And I think Missouri is somewhere here. But you see Mississippi, Oklahoma, Arkansas, Louisiana, Alabama, Tennessee, Kentucky. These are where we should be spending most of our energy developing and testing interventions and strategies where we can use the best practices we know now to make sure we make substantial improvements in reducing these risk factors. There are important geographic variations that we see. Here we're looking at the age standardized prevalence of heart failure, assessed as the number per 100,000 person. Again, this is the 2016 data. 2019 data have not been published yet, but the picture is the same. You see a substantial high prevalence in many Midwestern and Eastern states compared to the West. The highest seen here, New York, Indiana, Kentucky, and certainly the least prevalent states are Minnesota, Washington, excuse me, Alaska. I think the message here is that important geographic differences. We've studied this, we've published this. The time has come to actually focus on what strategies can help us implement the best practices we know so that we can reduce these high burden. Sometimes the national data also mask important differences that you see at the subnational level. Here, if you look in younger adults compared to older adults, let me point out that the scale is different. The scale is about 10-fold lower in younger adults. Which is what you would expect. But even within this lower burden state, the heart failure related death rates were 2.5 to 3 times higher in young Black men compared to young white men. Same story when you look at women. So in addition to the geographic disparities we see, we also have tremendous racial and ethnic disparities. You see that again in the older adult population. I also want to share with you the data on mortality rate. Even though we've made tremendous progress, these rapid declines from the early 2000s all the way through 2011, we're seeing in all these groups, you see that the rates remain much, much higher for non-Hispanic Blacks compared to non-Hispanic white or Asian Pacific Islanders. In fact, non-Hispanic Black persons were more than twice as likely as non-Hispanic Asian or Pacific Islanders to die of heart disease, both in 1999 as well as in 2017. Some improvement, but there is certainly more work to be done. Here I'm showing you the age-adjusted disability rate for all cardiovascular diseases. In men and women, the sex difference comes as no surprise, but again, huge differences at the state level. Mississippi, excuse me, standing out as very, very high. So these variations are important that we need to take into account. Let me summarize the key take-home messages. Cardiovascular diseases remain a leading cause of disease burden worldwide. Although the burden continues, is a decades-long rise for almost all countries outside the high-income countries. We need to pay particular attention to that middle group of countries that I showed you, where coverage for cardiovascular and other chronic diseases remains very limited. In fact, very concerning is that the age-standardized cardiovascular death rates have begun to rise in some locations where it was previously falling. So not only are we failing to make progress in some areas, we are beginning to slide, particularly in several Eastern European countries. Social demographic changes are important. The easy message for me to remember is social determinants are just as important as biomedical determinants. Worldwide, we see large gaps between guideline recommendations for management of cardiovascular disease and other risk factors, and what we see in routine care delivery. I know that doesn't happen at WashU. I should highlight that. And in fact, when you speak with every clinician, they agree that there are gaps in what we know and what we do, but that doesn't happen in their practice. We all say that. I think the time has come for us to recognize that it is more uniform than we see. And we at NIH should be very, very interested in seeing investigating initiated applications that specifically address novel ways to tackle this. And in addition, we must pay attention to the large disparities that we see in the total burden of cardiovascular diseases, largely attributable to modifiable risk exposures and then social environmental determinants. So what are the implications for these trends and these data that I've shared with you, especially as we look in the next decade, and particularly when we put it within the context of social determinants? Population aging is important. We don't have any drugs for that to keep everyone young all the time, but there are actually some things that from a public health perspective that we can do. I encourage you to take a look at this United Nations document. There are two of them. There's the population prospects and population aging. I think I have another slide I'll show you in a minute. But one of the things that struck me as quite impressive is that here we're looking at the percentage of the population aged 65 years and over in 1990 on the left, 2019 on the in the middle, and then by 2050, the projections that we expect. The truth is virtually all countries and areas are experiencing population aging. But if you look in the light greens, countries and regions where the proportion of people over age 65 is less than 10%, only 5 to 10%. But by 2019, you begin to see more blues, and the blues are where the percentage is 15% or greater. And by 2050, that's going to be the majority of the world. So really important that we pay attention to healthy aging. We cannot prevent aging, but if we can prevent the development of risk factors, we wouldn't have to worry about as many people suffering heart attack and stroke. And even if we prevent them from dying, there still is a huge burden of many years lived with disability. This is why population aging is important, and healthy aging is crucial. From the estimated 7 billion people in the world in 2019, this is expected to grow to around 8.5 billion by 2030, nearly 11 billion by 2100. So important that we pay attention to it. Two very important resources from the United Nations, the World Population Prospects and Population Aging. You see that the two areas that would, even after 2030, would still continue to see some growth, Sub-Saharan Africa and Central and Southern Asia. We really should take this into account. And these are also the areas that now we must start emphasizing healthy aging and preventing the development of risk factors in the first place. Second implication is social determinants are key. We spent a lot of our time and our effort in addressing healthcare and access to high quality care. Important, but they probably address only about 20% of the overall burden that we see. Talking with our patients and families and friends about healthy behaviors is crucial. They add another 30% or so, but there's a huge component that's attributable to socioeconomic factors, education, job status, family social support, social cohesion, income, and certainly community safety that would enable even individuals to practice these health behaviors. We need to do our best to recognize the crucial role of social determinants and how a large proportion of it traces back to your zip code rather than your genetic code. So absolutely important. We published this summary document highlighting the crucial role to continue to pay attention to our traditional risk factors at the same time as we highlight the socioeconomic status and begin to really address interventions that can make our biomedical model even more effective. Healthcare system changes are crucial, but so are the things we do in our communities, in our schools, certainly from individuals and families to our government policies at the local and national level. Here's a scientific statement that we published reflecting how the NIH and NHLBI is looking at implementing our strategic vision within the Division of Cardiovascular Sciences. My colleague, Dr. David Goff, who directs that division, led this effort. And as you see, no surprise to anyone that the first item listed is our efforts, our interests, our commitment to support and research that would address social determinants of cardiovascular health, as well as health inequities, finding ways to enhance resilience that's promoting healthy aging all the way from the very beginning, from peri-pregnancy through childbirth and early childhood to young adulthood. We shouldn't wait into adulthood before we try to find new drug targets or the best new drugs or the best new interventions. All that's important. I think the message today is we also need to address resilience. We also need to promote health, promote the prevention of the development of risk factors in the first place. Certainly, vascular dementia should be included as an important component of cardiovascular diseases and chronic diseases, and there's a lot we can do to improve that. There's a scientific statement of the American Heart Association published earlier this year, beginning to emphasize the crucial role of some of the factors that traditionally we as cardiologists and as internists and even as pediatricians, we haven't often highlighted as critical in our overall clinical management, but also in our research and in our partnership efforts to promote health. Housing plays an important role, whether it's housing stability, quality and safety of housing, the affordability of housing, and especially the quality of the neighborhood environment. It plays a role in our patients' ability to follow the instructions we give them about behavior change. So the more we incorporate these into our practices, the better. This chart shows the major drivers for cardiovascular disease, population growth and aging I've highlighted, but certainly this is where we can make huge changes by addressing risk exposures and the contribution of risk to disability-adjusted life years. I'd like to close by briefly addressing best practices, or maybe I should say promising practices. We never get to the point where we know absolutely the best thing to do, but we would take promising practices any day. But there's a real need for implementation and dissemination research. We all know the mantra in implementation science. It takes an average of 17 years for only a tiny fraction of new scientific discoveries to enter day-to-day clinical practice. And even in the United States, Americans receive on average only half of the recommended preventive and evidence-based interventions. Proof would always point out that this is all data that's true, published by Elizabeth McGlynn in 2003. But actually, the paper from Levine from the Brigham published 4 years ago showed the same thing. In spite of the decade of efforts after McGlynn's paper, the clinical quality of outpatient care delivered to Americans has not consistently improved. There continue to be deficits in the care that really pose serious hazards to the health of the American public. This is the Levine paper. On the left here, if you're looking at strategies that are recommended for diagnostic testing and preventive testing, we do okay, around 80%, but I should say 70 to 80%, but that hasn't changed in the last decade. If you look at what is recommended for care, for counseling and medical treatment, we actually do worse than for testing. And a tiny rise from 2002 to 2012. Chances are, if you look today, this is where we're doing. We ought to be doing 80% better. The chart on the right is de-implementation research, avoiding inappropriate care. And it's good news that we're certainly doing better, although we all would like to be around 100%. This is inappropriate medical treatment or inappropriate imaging. When it comes to screening, inappropriate screening and inappropriate antibiotic prescribing, we're still around 50%. So a lot of room for improvement. There's no question at all that if you take effectiveness and cost into account, we can define practices that are best buys. But for the same reason, if we look at practices that and interventions and strategies that cost a lot, but for which the effectiveness is uncertain, these are clearly wasted buys, and we should be doing de-implementation and stopping these interventions and doing everything possible to promote this. Of course, what's considered a best buy in one context or a wasted buy in another is just a question of effectiveness. It's more than just a question of effectiveness, and other factors must be taken into account, including ethical implications, culture, practical factors, but certainly interventions that are not cost effective in one context might still be appropriate in another. But particularly when we take social determinants into account, we really need collaboration beyond internal medicine. We need to engage other colleagues. I'm going to skip this data in the interest of time and highlight the fact that we have a unique opportunity to start our interventions early in life. We shouldn't wait until adulthood, because as I showed you, with the trends in population aging and population growth, we will not have enough resources for enough drugs and enough surgeries and enough interventions to address this. Prevention beginning in early childhood is key. Taking a socio-demographic and socio-ecological perspective is important, but really paying attention to the entire lifespan, from preconception to healthy pregnancy, to healthy childbirth, and paying attention to the consequences and impacts of childhood and adolescence before adulthood is key. This is a complex figure, but it brings everything into focus: the biological, psychological, social, behavioral, all put within the context of an entire lifespan. I'll close by highlighting the importance of training. We do a lot to support research, and we take great pride in the training that our faculty, our mentors do to promote career development. I had the opportunity to address the 50-year journey that we've seen, at least for cardiovascular epidemiology and career development. We should be looking at the same for implementation, de-implementation, dissemination research, but training is key. I should say that at the National Institutes of Health, and especially at NHLBI, we're very, very, very proud of the work that Washington University, your faculty and staff, your fellows, the house staff, and medical students that are doing. We're very proud of our iNexIS implementation science effort, the work the Institute for Public Health is doing, and certainly congratulate you in your Global Health Week. I know I missed a lot of outstanding lectures that you put together this week, but we're all very proud of the work you're doing to advance global health. So here are my 10 concluding messages. It's all in the handout that I provided. My slides are also available to you. I will not read each one of them. I'll go through, but I'll highlight one just to say that I know you've had lectures on COVID-19, so I didn't cover it, but this is a huge national global pandemic, but it's taught us some lessons that prevention is important, that communities are important, our neighborhoods are important, and social determinants are important as we strive to achieve good health, health equity, and ideal cardiovascular health for all. And that there's a lot that we can learn from assessing global and local trends of disease burden and putting it into an appropriate social context. I'll stop here and say thank you very much for this wonderful invitation. And again, a big thank you and congratulations on Global Health Week. I will stop here. Thanks.
Thank you so much, Dr. Benza, for that wonderful presentation. We have a few minutes for some questions, and I wanted to start by maybe asking, what are the programs that you foresee coming from NIH, NHLBI in particular, to address some of these issues that you have mentioned?
Yeah, a really important question. Thanks, Dr. Davilá. As you know, we are limited from talking about specific programs until they become publicly available. But I think it's fair to say that we pay particular attention to what the data and the science is telling us. So burden of disease, burden of risk factors, especially the risk factors that are rising, the areas of the world where these are most prominent, any interventions, especially that focus on best practices or promising practices today that can be put within appropriate context would be a high priority for us. So hypertension is always a high priority for us. Actually addressing health conditions from a syndemics approach so that not blood pressure here, cholesterol there, and obesity on the other side, but thinking of people living with HIV, people living with diabetes, people who have 2 or 3 risk factors. So the concept of multimorbidity in the global context is crucial. And we hope that we continue to have the bipartisan support we have from Congress, and we have enough funds so that we can send them out to institutions such as yours, really on the cutting edge of advancing public health.
Thank you. I have a question for our department chair, Dr. Fraser. Terrific talk. Thank you. What are the opportunities from NHLBI to foster more career development and research funding in global health?
Really, really very important. In fact, Dr. Fraser, I would go a step further to say it really shouldn't be just NHLBI. It should be all the institutes. We live in a global community. I should have added to the lessons we've learned from the pandemic is we're not isolated from other countries, and I think we recognize that. We're very fortunate to have a real champion at NIH, Dr. Roger Glass, who directs the Fogarty International Center, and training, career development, strategic educational partnerships. All of these are major priorities. I should also say that I'm very, very proud of Dr. Francis Collins. He made it a major priority almost a decade ago at the beginning of his tenure that this is a priority. So yes, whether we're talking about career programs, individual or institutional, whether we're talking about our fellowship programs and our training programs, this is the time to send your best ideas to us. We may not have all the resources to support everything, but we can guarantee you that the most meritorious applications we do our best to fund. We also work with our sister institutes. So there are times when the ideas you propose for training and career development span heart disease and cover diabetes. We find ways to work with our NIDDK, our Diabetes, Digestive and Kidney Disease Institute, the Institute for Minority Health and Health Disparities, or even our Center for Accelerated Translation. So we are very, very proud of the support and the commitment. I should mention, Dr. Freya, that several of your faculty who serve as peer reviewers, they play a crucial role in this effort. And so hats off to them, and we'll continue to look for more resources so we can train more and more. Thank you.
Thank you for that answer. I have two questions from Chris Carpenter. One of them relates to aging populations and the topic of improving healthy aging in quotation marks. And then how to apply, what are the challenges of failure to apply medical knowledge in clinical practice? The knowledge decay, how to slow knowledge decay and accelerate knowledge transition or translation, sorry. So two questions.
Yeah, Chris, these are very important questions, and I don't think there are easy answers. However, in implementation science, our mantra is to embrace complexity. So healthy aging, I would say that the first teachable moment is, even though we're thinking of healthy aging, we should not be focusing on the elderly. We should be focusing on youth and children, all focusing across the entire lifespan. When it comes to the challenges about knowledge translation and knowledge decay, I think we need to stop asking doctors to do more and more and more with the limited time that they have during the hours, but find ways that would make it easier for them to do their work, leveraging technology to facilitate doing best practices. I still remember my clinic days where before I walk into the patient's room, there will be a sheet of paper at the door, but all they would have is the patient I'm going to see and maybe the chief complaint or the diagnosis. Wouldn't it be wonderful if for every physician, every nurse, every pharmacist seeing a patient today, we use our technological advancements to describe every single best practice recommendation that applies to the patient and even identifies for you what they already on, give you a wonderful green check, but also highlight what they should be on that they're not on. It would make the practitioner's job easier. So I don't think the solution is asking doctors to do more and more. The solution is finding ways to better use our time and using technology to support. Point of care decision support, that really does most of the work before we even get to the patient. That's what we're looking for, and we'll be delighted to consider investigator-initiated applications that highlight this critical challenge and find ways for us to support that research. Thanks for that question.
Yeah, thank you. It's a little bit past 9 o'clock here in St. Louis. Ava, are we out of time now? Sorry.
Yeah, usually we do wrap up around 9, but there are, if you would like to answer one more question, there are still some people who have time, but I went ahead and shared the codes for those who need to go on with their morning. So if Dr. Mensah is, that's up to you guys at this point.
Well, if Dr. Mensah, you mind answering 2 more questions?
I'll be very happy to do so.
Thank you. We have one from AP Barrett. How much is the improvement in the US limited by lack of health insurance? Very important question.
Yeah, very, very important question. There's no question at all that access to care is part of it, and lack of insurance is part of it. I would also say sometimes we create this artificial dichotomy of those who have insurance and those who don't have insurance, obviously both important. But I'll also submit that there's a large number of people who are inadequately insured. So they may have insurance, but they actually cannot afford the quality care they need to receive, particularly for preventive care. And so they wait until they have something more serious so that they can use their limited suboptimal insurance to take care of that. It would be wonderful. And that's where in a global public health week, highlighting the policy implications that support our work. Lack of insurance is important, but inadequate insurance is important, so that when someone has to pay a high copay, why would they go in when they don't have symptoms and they wait until they have a disease? I think that's inappropriate. We have to find ways to make it easier to be able to cover everyone and have basic fundamental preventive services available to everyone.
Thank you. We have a question from Kara Walters. She's an occupational therapy student, wondering what you think the role of interdisciplinary teams is in the implementation of promising practices in public health.
Carol, that's a wonderful question and a very important one that we need to pay more attention to. I recognize that very often we pay tribute to and highlight individuals for their outstanding accomplishments in science. I think we're beginning to recognize the value of team science and a multidisciplinary approach to solving these questions. So your question is very relevant. We're beginning to do more, and in the coming years, you see us put out funding opportunity announcements that require the transdisciplinary collaboration. As I mentioned in the talk, when it comes to addressing social determinants of health, this is where we need to go beyond internal medicine, partnership with occupational medicine, partnership with the School of Public Health, partnership with the engineering. The multidisciplinary approach is key. We've started trying this out. We had a sickle cell disease challenge that really recognized not just hematology expertise, but actually social determinants, social services, communications. So simple answer is yes, yes, and yes. Multidisciplinarity is the way to go.
Thank you so much, Dr. Mensah, for a phenomenal presentation today. We are really proud that you are, part of us at WashU, and really grateful for spending the time with us today. Thank you to you.
Thank you very much. Thank you very much. It's really wonderful and a delight and a really a privilege for me to be here. I really appreciate the invitation. Thanks.
Wonderful. Thank you so much. Everybody have a good day.
A wonderful day and a wonderful rest of the week to everyone. Thanks.
Thank you.
Have a great day.
Bye.
Bye-bye.